Carol is a very good colleague of mine with training in both agricultural economics and health economics, which means she is absolutely the perfect person anywhere to moderate a discussion on the role of food insecurity in health. Back to you, Carol.
It's my pleasure to moderate this session. Our first speaker is Hilary Siegelman, who I just met today. And I'm looking forward to moderating this panel because I'm interested in learning about the research that's going on here in the Bay Area. She's an associate professor in the Department of Medicine, Epidemiology, and Biostatistics, and she directs the Food Policy, Health, and Higher Research Program at San Francisco General Hospital. Dr. Siegelman's expertise is in food security in the U.S., and I think we've been having a lot of discussions around global local, and so to that, I'm looking forward to today's presentation.
Thank you. I'm really honored to be here today to talk to this group. There are some amazing people in the room, and I'm really honored to talk to you about this topic, which is food insecurity in the U.S. and our journey to really try to understand what the economic cost is in the health sphere. So I'm going to try to answer two questions for you today. The first is, does food insecurity impact health in the U.S.? And if so, what are those economic implications? So I'm going to start with some basic definitions. Food security in the U.S. is conceptualized a little bit differently than food security globally. The USDA defines food security as access by all people at all times to enough food for an active, healthy life. And the flip side of that, food insecurity, as a household-level economic and social condition of limited or uncertain access to adequate food. Now, in the U.S., the way food insecurity is assessed and conceptualized is as a lack of resources, primarily financial resources. So it overlaps with many other reasons why access to food may be challenging, but we're really talking about food affordability in the context of food insecurity in the U.S. In 2016, the most recent numbers available, 12.7%, or 1 in 8 U.S. households, reported being food insecure. This includes the 7.4% of U.S. households that reported low food security, in which households had to change the quality of the food that they eat in order to make their food budgets, and an additional 4.9% of households with very low food security who had to alter both the quality and the quantity of food that they ate in order to make their food budget. This is reducing the size of meals, skipping meals, going entire days without eating in order to make ends meet. This is not a recession problem, since food security measures have been consistently undertaken annually by the USDA. In the mid-1980s, the food insecurity rate in the U.S. has stayed relatively stable between 11 and 14%. So before we can really understand the economic implications of food insecurity, we have to understand the differences between food insecurity and hunger. Hunger is a physical sensation that we all feel when our Indian buffet doesn't show up till 12:30 and we are anticipating it at noon, or because you're on a diet, or for whatever other reason. But food insecurity includes that physical sensation of hunger and all of those coping strategies that people engage in order to avoid that physical sensation of hunger. And these coping strategies are adaptive in the short term. They keep you from going hungry. They keep you from losing weight. But what we understand is that these coping strategies, when maintained over years, decades, or even a lifetime, which is a very typical pattern of food insecurity, both in the U.S. and globally, become maladaptive in that they can predispose to a higher risk of obesity and diabetes and other chronic disease. And once you're chronically ill, the poorer ability to manage your illness. And these coping strategies include shifting dietary intake towards low-cost foods, which tend to be nutritionally poor and calorically dense. More saturated fats, fewer fruits and vegetables. Concentration on higher filling foods, a smaller variety of foods that you know are going to fill you up and keep you full until your next meal, avoiding food waste, and binging when food is available in anticipation of food inadequacy in the future. These are the types of coping strategies that we think predispose people to chronic disease. So as you can imagine, particularly in the context of a very stressful household environment, food insecurity is inordinately stressful. People engage these coping strategies which have impacts on physical and mental health. Those impacts and those poor physical and mental health outcomes result in increased healthcare expenditures and decreased capacity to maintain steady employment. This forces spending trade-offs and decreases household income, which puts you at increased risk for food insecurity, and it becomes a cycle. Now, one of the ways that we've tried to understand the health implications and the healthcare costs associated with food insecurity is by taking advantage of of the typical pattern of food insecurity in the U.S., which is very cyclic and episodic. So most food insecure households are predominantly experiencing adequate household food, but for discrete and relatively short episodes of time, 3 days, 5 days, 7 days, they experience a snap of food inadequacy. And on average, these snaps of food inadequacy happen approximately 7 times per year. Another time we'll talk about all of this variation, but for the purposes of today's talk, what you need to understand is that in most households, those episodes of food inadequacy happen at the end of the month because that's when household food budgets tend to be the lowest. And so we've really taken advantage of these compensatory strategies and used diabetes as a model to try to understand how these cycles of food shortage and food adequacy might impact compensatory strategies and therefore health outcomes. Because as you can imagine, during episodes of food shortage, you may be more likely to miss meals or reduce your caloric intake, while during food adequacy, you would be more likely to systematically overconsume and shift to energy-dense foods. And if you are a physician in the audience, you can very clearly tell using diabetes as a model that might predispose you during some times of the month to low blood sugar and during other times of the month to high blood sugar. And so one of the things we did to understand the economic costs of food insecurity was to take advantage of this hypothesis to look at the day of the month in which people were admitted to the hospital for low blood sugar across the state of California. So we looked at every admission in the state of California over a 10-year time period to the hospital, and then tracked the day of the month in which people were admitted. And you can see in the green line a graph of the day of the month for the entire population, and then in the red bar at the top for the lowest income population. And what you can see is low income in general is associated with an increased risk of a low blood sugar admission at every day of the month. But in that last week of the month, the risk for a low blood sugar admission goes up by 27%. And we think this is really related to the inability to access food in the last week of the month. So, does food insecurity impact health? I don't have time to go into much more data. I will tell you that with diabetes it does. I gave you one explicit example, but I could have talked about obesity, high blood pressure, heart failure, etc. So let's then, in my last 5 minutes, get into the economic implications. Because those of you who are healthcare economists will know that the fact that we pay an average of $17,564 for an inpatient visit for low blood sugar in 2011 would make it seem a little bit ridiculous in the context of the monthly food costs for a family of 4 by the USDA's estimates being $657 a month. So to understand this discrepancy, we have to look at what kinds of resources people in food insecure households are using to make ends meet. And for the purposes of this discussion, we're going to concentrate on the largest because this gives us the opportunity to study the economic costs. And in this case, it's the Supplemental Nutrition Assistance Program, or SNAP, formerly known as food stamps. This is the largest federal nutrition program in the country. It serves about 1 in 7 Americans at a cost of about $70 billion annually, and provides approximately, on average, $1.40 per person per meal. So we look at this, and if we want to understand whether there's economic implications here, one of the things we can do is say to ourselves, can SNAP make a difference? Meaning we know food insecurity is having an impact on health. If we use a strategy to increase food security, can we reduce that end-of-the-month increase in low blood sugar admissions? And to do that, I, with my colleague Sanjay Basu, thank you Sanjay in the back, have taken advantage of a natural experiment, the American Recovery and Reinvestment Act, which was a temporary and quite substantial increase in SNAP benefits that happened between May of 2009 and October of 2013. And we asked the question, what happened to that end-of-the-month increase in low blood sugar admissions during that period of an increase in SNAP benefits? And to do this, we used a different data set, commercially insured adults, so overall a wealthier population, and looked just at people between the ages of 19 and 64. And what we found is, in general, across this time frame, the end-of-month increase in low blood sugar admissions persisted. But we couldn't find that relationship at all between May of 2009 and October of 2013. It disappeared. The increase in SNAP benefits reduced or eliminated that end-of-the-month increase in hypoglycemia. And if we took the value of those admissions that were averted and added them up across that population of commercially insured adults in the U.S., it suggests that the emergency department and inpatient hospitalizations averted totaled $54 million. Now, many of you know that low blood sugar admissions are very rare events. And so this is quite an underestimate of what food insecurity may be costing us. And one of the ways that we can better understand the full economic costs of food insecurity on the healthcare system in the U.S. is to look at the relationship between food insecurity and subsequent healthcare expenditures. And this study asks people in the National Health Interview Survey whether they're food insecure, and then follows them through with the Medical Expenditure Panel Survey for the subsequent 2 years to see what happens to their medical expenditures. And you can see that the difference in healthcare spending on average across the U.S. between a food secure and food insecure person is about $1,800 per month, per year, after adjusting for socioeconomic status, which you can see below. And if you add that up across the population, it suggests that additional healthcare expenditures attributable to food insecurity in the U.S. are $77.5 billion. So then your next question may be, if this is the case, can we improve this situation by increasing food security? And again, we can use SNAP as a way of trying to understand how efforts to improve food security can reduce this impact. And in fact, if you look at what you would predict healthcare expenditures to be in someone who's on SNAP and who's not on SNAP, what we find is that enrolling in SNAP is associated with a $1,400 savings per year in healthcare expenditures. Or to be specific about the numbers, a low-income eligible non-participant in SNAP has annual healthcare expenditures of about $5,800 per year, with a matched SNAP participant having healthcare expenditures of about $4,400 per year. So I only have 1 minute left, but I want to conclude with a bit of a caveat of why we talk about costs. The Hunger Safety Net, SNAP in particular, was designed to feed people, not to save healthcare costs. And so we're very reluctant to give the impression that the reason we support these programs is to save healthcare costs. But we have very much noticed, and as all of you have, that not only are there very strong incentives for health systems to reduce costs, but costs really help to align sectors among which there's very heavy tension nowadays in who's going to take responsibility for addressing these social determinants of health. Is it our healthcare systems? Is it our social safety net? Is it our public health system? And we very well know from this work that documenting these excess health costs support programs that are proven, like SNAP, to have an enormous impact. So if so, what are the economic implications? They are enormous. We think about $77 billion, but we do have effective strategies for response. We have a SNAP system that's in every county in the U.S. and is already enrolling a huge number of people, although not providing adequate food. And with that, I'm going to say thank you to you guys, but also to Seth Berkowitz and Sanjay Basu, who have really helped to make this very, I think, compelling economic case with me.
Thank you. That was great. Let me introduce our second speaker for this panel. Sherry Weiser is an internist and associate professor of medicine at the Division of HIV, Infectious Disease, and Global Medicine at UCSF. And as part of her work, she is focusing on food insecurity and its relationship to care of vulnerable populations. She has extensive experience both in the U.S. and in a number of countries in sub-Saharan Africa. So we're looking forward to your presentation. Thank you.
Thank you very much. In the next short while, I will give a brief overview of how food insecurity increases morbidity for HIV and chronic disease, focusing more specifically on the sub-Saharan African context, and then we'll look at food security interventions as a way to reverse the vicious cycle of food insecurity and poor health. So unfortunately, hunger and malnutrition are again on the rise in sub-Saharan Africa. It's now estimated that 31% of individuals in the continent are severely food insecure and 22.7% are undernourished, and these rates are increased from a few years earlier. The prevalence of overweight and obesity also continue to rise, and the cause of these shifts in recent years are thought to be related to adverse climatic conditions as well as rising conflict. So much of my work has focused on the intersection between food insecurity and HIV, and worldwide, food insecurity and HIV can be thought of as syndemic issues. So the regions that have the highest prevalence of food insecurity, shown in the top maps in the pink and red colors, strongly overlap with those that have the highest HIV prevalence, shown in the bottom maps in the pink and purple colors. Food insecurity disproportionately impacts poor women across the world. In fact, it's estimated that about 60% of undernourished people worldwide are women and girls. And this occurs in part because women prioritize feeding their families and their children over feeding themselves, and also are often forced to leave work or schooling early to serve as caretakers. So you find more female-headed compared to male-headed households being food insecure. And even women in relationships are often more food insecure than their male partners because of unequal household food allocation. In Uganda, we found that women with lower sexual relationship power were also more food insecure and malnourished than those with higher sexual relationship power. So because of this interplay between food insecurity and women's disempowerment, women at times find themselves in a situation where they're compelled to engage in risky sexual practices. And here's a quote from a woman in Botswana describing how food insecurity was perpetuating the HIV epidemic there. She said, "Women are having sex because they are hungry. If you give them food, they would not need to have sex to eat." And another woman described her choices rather starkly. She said, "Either my children and I starve tomorrow, or I have sex with someone today and maybe get HIV and will then die 5 to 10 years later." So the associations between food insecurity and risky sex have been documented in quantitative studies around the world. For example, in population-based studies in our group in Botswana and Swaziland, Brazil, and Nepal, we found that food insecure women had higher odds of unprotected sex, sex exchange, and symptoms of sexually transmitted infections. And we and others have also found similar things in the domestic context. So here's a conceptual framework somewhat parallel to the conceptual framework that Hillary talked about, looking at the vicious cycle of food insecurity and poor health. So food insecurity directly contributes to poor nutritional status, poor mental health, and poor adherence to treatment and care recommendations, which then increases both incidence of chronic disease and worsens outcomes among those affected. This then drives utilization of expensive healthcare services, as we've heard from Hillary, like ED visits and hospitalizations, which increase healthcare costs. And then as a result of the increasing disability, this further entrenches individuals and families into poverty and unemployment, which then perpetuates a vicious cycle between food insecurity and poor health. And I'll refer back to this figure in the rest of the talk. So first of all, looking at the nutritional pathway, food insecurity is an important contributor to both micronutrient and macronutrient deficiencies, as well as to the growing obesity epidemic, as Hillary mentioned, and these are all important pathways towards worse chronic disease health. So as an example from Tanzania, one study found that food-insecure, HIV-infected children had 7 times greater odds of being stunted and 8 times the odds of being underweight compared to individuals who were food-secure. Food insecurity is also a very important driver of poor mental health, contributing to depression, anxiety disorders, and drug and alcohol use disorders. Again, important pathways towards worse chronic disease health. As an example of this, in a recent global analysis from 149 countries, including 35,000 individuals from sub-Saharan Africa, and the figures there are from the sub-Saharan Africa subset, you can see that food insecurity was associated with worse mental health and a dose-response relationship as the severity of food insecurity increased. Food insecurity also contributes to poor health behaviors like medication non-adherence, treatment interruptions, and missed clinic visits, negatively impacting health. For example, in Uganda, we found that among HIV-infected individuals, those who were food insecure had 56% higher odds of antiretroviral non-adherence compared to those who were food secure. And in fact, in the context of HIV/AIDS, food insecurity negatively impacts individuals along the entire cascade of care. For example, food insecure individuals have 3 times the odds of acquiring HIV, 2 times the odds of missing their clinic visits, 70% higher odds of failing HIV therapy, 45% higher odds of progression to AIDS, and are 2 times more likely to die compared to individuals who are food secure. So how do we begin to address this vicious cycle of food insecurity and poor health? And we've heard some important information from Hillary on this. So there are a number of possible interventions to consider, from targeted food supplementation in food banks and clinics, to food stamps and vouchers, to even more upstream interventions like cash transfers for food and livelihood and vocational training programs. So looking at some of the evidence in sub-Saharan Africa, and this is specifically looking at food supplementation programs, the data do suggest that they can reverse the vicious cycle of food insecurity and poor health I've just shown you. For example, along the nutritional pathway, Jason Nagata from UCSF found statistically significant improvements in weight and body mass index among patients in Kenya that were participating in the Food by Prescription program. There's quite a bit of domestic data showing improved depression among people on food support programs, and at least one study in Kenya found similar things. And in Zambia, a study among HIV-infected patients found that those who received food support had 1.5 times higher odds of excellent ART adherence. There's less data on hard clinical endpoints in the sub-Saharan African context, but at least one study in Uganda found that recipients of an economic intervention that included food support were less likely to die. So food supplementation is critical and is very important in many contexts and certainly is cost effective. However, for some people, relying on clinics or health programs for food may be socially unacceptable, and it may contribute to ongoing anxiety and uncertainty about the food supply, and in resource-poor settings, it may be difficult to scale up in a variety of settings. So there's a movement now towards more livelihood approaches that may address the root causes of food insecurity and really help address all of the various pathways through which food insecurity negatively impacts health. And when you're thinking of some of these longer range approaches, it really does require transdisciplinary collaboration. So moving beyond just the health sector and NGOs to bringing in non-traditional partners like agriculture, finance, and other partners. So we're testing one such approach along with my co-principal investigators, Craig Cohen at UCSF and Elizabeth Bakusi at the Kenyan Medical Research Institute. Our intervention is called Shamba Maisha, which means farming for life in Kiswahili. And the goal is really to target the root causes of food insecurity and poverty in the region, which in this case is inconsistent rainfall and increasing frequency of drought in the setting of climate change. So we tested this in 2 clusters of 140 people. Our intervention had 3 components: a microfinance loan to purchase farming implements and a human-powered water pump, the water pump itself, and education in sustainable farming practices, as well as financial management. So going back to our framework, we had hypothesized that this multi-sectoral agricultural intervention would first improve food security and household wealth, and then through the various pathways I've already reviewed, as well as through enhanced empowerment, would lead to decreased morbidity and mortality. And here are our findings, and you'll note that the intervention groups are shown in the blue circles and the control groups in the red X's. You can see at baseline there were very high and similar levels of food insecurity in both groups. By 6 months, we already saw statistically significant improvements in food insecurity in the intervention compared to the control group that persisted throughout the rest of the trial. Looking at viral suppression, you can see that at baseline, there was actually a higher proportion virally suppressed in the control group compared to the intervention group. Again, by 6 months, these trends had reversed, and the statistically significant improvements in viral suppression persisted throughout the rest of the trial. We also saw similar and statistically significant improvements in CD4 cell counts. And as a measure of empowerment, we saw statistically significant improvements in self-confidence in the intervention group. So our qualitative data really affirmed the nutritional, mental health, and behavioral mechanisms through which food insecurity was, through which the intervention was improving health. So on the mental health pathway, a participant says, "It has given me hope and will to do my things, not like before when I used to be hopeless and scared. I also have the will to go about my duties and farm, from which I get food and money, thus living like any other person." And on the behavioral pathway, a participant says, "I find getting to the clinic to be a little easier because now I'm able to get money for my fare to the clinic. I get the money from the farm produce." So at the beginning, I mentioned that food insecurity was contributing to women's disempowerment, and one benefit of the intervention was improvements in women's empowerment, and that also contributed to a reduction in violence. So here's a quote from a male participant. "I used to be violent. The violence would mostly relate to money issues, and this is the root cause in many homes. But now she manages the farm. If I need some money, I can always ask her. So it is taking care of some form of domestic violence to some very big extent." And we're now in the process of scaling up this intervention in a 16-site randomized controlled trial. Craig Cohen, Dr. Bakusi, and I are leading a study looking at adult HIV clinical indicators, and Lisa Butler has a paired R01 looking at child health, nutrition, and development. And in the last minute, I just want to go back to what I said at the beginning of the talk, which was that climate change was a strong contributor to the increasing prevalence of food insecurity in recent years, and take a minute to describe how climate change is affecting food insecurity. And specifically, there's many mechanisms through which climate change affects food availability. For example, the increasing frequency of drought is contributing to large-scale crop losses. Higher temperatures reduce crop yields by decreasing the rates of photosynthesis and also reducing soil moisture. Heavy rains and storms can flood fields, erode soils, and wash away crops. Higher CO2 levels and temperatures are also contributing to thriving plants and pest diseases, and many of these mechanisms also contribute to animal deaths. So while food insecurity is certainly being affected by climate change, the regions of the world that are already have the highest prevalence of food insecurity that I've already shown you in those top maps strongly overlap with those that are projected to continue to have the highest vulnerability to climate change. So going back to our Shamba Maisha intervention, we're trying to address sustainability in a few ways. First of all, we're training farmers on using sustainable farming techniques, including practicing regenerative agriculture, where they're trying to replete the soil of previously depleted nutrients. And finally, the intervention helps mitigate a negative impact of climate change by enabling the farmers to irrigate their crops during the increasingly long dry seasons. So in summary, we've seen that food insecurity and poor health interact in a vicious cycle, that food insecurity negatively impacts health through nutritional, mental health, and behavioral pathways. We know that improving food insecurity can address multiple health problems simultaneously. And when considering food insecurity interventions, I strongly urge you to consider environmentally sustainable approaches. Thank you very much.
Thank you. Thank you to both of our speakers. We have 15 minutes, is that right, until the next session?
Hi, Gila and Mescal. For the study in sub-Saharan Africa around food insecurity in African regions, the interventions were around agricultural interventions and farming practices. Are there any ideas of implementing interventions around policies or regional political structures that affect how farmers are able to sell their foods, use their foods, monocropping policies within countries, things that affect what type of crops the countries build and so on? Since a lot of these cultures face some of these global issues before colonialism and so on, and a lot of these insecurities were seen now after colonization, disturbing the way the people naturally cropped and so on.
Yeah, so I'll just say that, there are many different kinds of interventions going on throughout the continent to address food insecurity. That intervention was just one of them. And I think some of those are, it differs in different countries. Some of those are more at a country level. Many are NGO run, trying to address different kinds of livelihoods in different ways. The World Food Program, for instance, for HIV-infected patients, also has food supplementation in clinics. That's part of the picture. But one of the big gaps, and I think that part of the reason that we don't know necessarily all of the interventions in terms of their health impacts, is that there's a big disconnect between the interventions that are ongoing and the evaluation of those kinds of interventions. So one of the things that many of us in this room are trying to do is get better evidence out there about the impacts of the many on-the-ground interventions on, everything from agricultural practices to food security to nutrition to health impacts, to understand what's really working.
Thank you. Other questions?
Yeah, I'm Dean Schillinger from the Center for Vulnerable Populations. First of all, congratulations to both of you and your teams for all the incredible work you've done over the last decade or two. I have a two-part question, mostly for Hillary. It's getting back to the economics issue and more macroeconomics. Could you give us your perspective on the role that the Farm Bill plays in either the problem of food insecurity and the nature of the food that's available to low-income people, or the solution to food insecurity? That's the first question. The second question is a smaller one, and Sherry touched on this a little bit with her outcomes. Have you looked at the ways in which food insecurity contributes to healthcare expenditures related to mental health specifically? Is that even possible to do?
Thank you, Dean. Let me start with the Farm Bill. Most of you know that the Farm Bill is being renegotiated now, needs to be renegotiated and renewed in 2018. The Farm Bill has enormous implications for food insecurity in the U.S. SNAP, as I mentioned, formerly food stamps, reduces food insecurity by about 54%. So very, very effective program at reducing food insecurity. And the Farm Bill sets funding for SNAP programs. Now, SNAP is an entitlement in the U.S. Every person who meets broad eligibility criteria for SNAP in the U.S. gets SNAP. But there are many ways that the federal government can influence who is likely to enroll and who is not. And that's all on the table in the 2018 Farm Bill. So the general mantra around the Farm Bill is to protect and defend SNAP and to make sure that it doesn't get block granted to states, which would probably spell the destruction of the program. There are a number of other federal nutrition programs that also reduce food insecurity rates. The National School Lunch Program, the Emergency Food Assistance Program, there's about 5 others. The other question about the food industry, for most people, that's really sort of couched as, what's the impact of corn subsidies on making healthy food more expensive than unhealthy food? And while that is an easy place for us to understand as lay people, most economists think that the problem is not in subsidies for corn. The real challenge that, in fact, fruits and vegetables are probably way cheaper than they should be because the labor that goes into the harvesting and the agricultural practices in the U.S. is so much cheaper. We pay people so much less than they should otherwise be paid, and so the fruits and vegetables are actually artificially low in price in the United States, and most people think that the challenges are really around the perishability of fruits and vegetables, raising the cost, and corn subsidies resulting in corn syrup, which makes food non-perishable, shelf-stable, which has a huge economic benefit in the marketplace. You don't have to move that product fast. It doesn't have to be destroyed if nobody buys it at Whole Foods, et cetera. So that's sort of the basic answer to your question. We know if we subsidize fruits and vegetables more, people buy more, both in workplaces and in grocery stores. And in terms of mental health, the only study that we've done personally showed that food insecure people in San Francisco who are in the mental health system are much more likely to utilize psychiatric emergency services and are much more likely to report mental health exacerbations. And that obviously has a cost to it that we've not yet quantified.
I'm Medina. I come from Senegal, which is a French-speaking country. So excuse me for my English. I would like to point out two main factors who impact food insecurity in Africa, mainly in sub-Saharan Africa. The first one is the immigration problems, and the second one is the invasion of industry distributing foods in Africa coming from Europe. So the first one related to immigration is a protective factor because people from sub-Saharan Africa who live in Europe or America send a lot of money to support their family, which is good to protect family against food insecurity. I'm not defending immigration at all, but I think that it's a good factor of protecting some family from food insecurity. And the second one, regarding chain food distribution coming from Europe and settling up in Africa. There are two main problems from that, because people are more eating high calories food and having more diabetes, more obesities. And the other part, which is the worst one, is they are killing the small farmers, which is very bad for food security, particularly for women. So I think that regarding to this element, we need to have strong geopolitical decision made to protect those small farmers. Thank you.
Thank you. I think that was a statement about globalization and impacts on both probably U.S. and African settings and probably every setting. So thank you for your comments, and thank you for two great presentations.